All right, folks, thank you so much for the invitation. It's a little tough after those two talks. What's left to say? I'm partly thinking I just open it up for questions and we end now, but it's all been covered. So a couple of disclosures and then I'll go through this. So first of all, I love podium talks. I'm not sure if any of you can see me over the podium. I'll wave every once in a while so you know I'm still here. So I'll try to cover things a little bit different. There's going to be some overlap. This is me. I am in Boston. I'm a dermatologist and a rheumatologist at the Brigham and Women's Hospital in Boston. I checked the weather. Normally there's a big disparity. Today it's about the same. It's like in the 50s and gray. So, more or less the same. But normally it's delightful to escape to warmer weather. And these are my disclosures. So I'm going to talk a little bit about the co-management piece. And I want to start first with gaps. A little bit more sort of the rheumatology facing gaps. And I think you've heard this. Some of this will be reinforcing to what my colleagues have already said, but I want to take a bit of a rheumatology angle on this. And unfortunately, across the breadth of psoriatic disease, if you like that term, we're siloed in our care, right? We have Ken doing psoriasis care as the dermatologist, from a skin perspective. We're obviously sitting in the rheumatology world, worried about joints and the domains of disease around psoriatic arthritis. We had that lecture from Philip yesterday about axial disease, thinking about all the different components there. There's heterogeneity, even within these two distinct areas. And then we have cardiovascular comorbidities and, the primary care and the cardiologist there. We have other conditions to consider and the breadth of comorbidities, and we'll talk about that as well. So there are many gaps, right? And there's gaps in awareness. There's educational gaps between us as specialists, and there's access issues that came up a moment ago. And of course, time and resources, right, really keep the gaps open here between these areas and ultimately harm the patient from getting complete disease control. And here we are building bridges, right? So RheumNow Live is filling some of the educational gap there. But I want to focus a little bit on interdisciplinary care models, on research and innovation in this area, and how we start to think about closing these gaps a little bit more. You may notice the first author on this article, as they say where I come from, Addy, is listed there. And this is an important one. I want to use this to frame some of our discussion because what this essentially shows is that in order to maximize quality of life for our patients with psoriatic disease, one has to, maybe not surprisingly, but I'll pick it apart a little bit, not only control their joint disease or maximize or optimize their joint disease, but also their skin. And that's not just the really bad patients that we saw a moment ago in the photos. It's also patients with 3% body surface area and more. So it still does matter very much. And I won't. Ken, in a moment, I will unfortunately show one of the treat to target slides, but I will give a caveat. I promise I will. There's a caveat when I get to that. But do remember this because it really does matter to patients and most patients. Is it different for my 70-year-old male VA patient with 3% body surface area than it is my 17-year-old female patient in the office? Possibly. I don't want to draw or over extrapolate there because obviously it's a shared decision-making discussion. But the point is the skin still matters. So what are some of the rheumatologist gaps? I think although there is the classic plaque psoriasis patient that we saw again in Ken's presentation, there is often a differential diagnosis. I'll show you a few where there can be some gaps around here, especially in non-plaque or non-obvious psoriasis. Comfort with topicals and combination therapies you've been hearing about all morning. We'll talk about that a little bit. Comparative effectiveness data. We got a beautiful talk from Bruce about that this morning, but really staying up to date with that so we understand what we might be choosing or what we might be discussing with our patient who still has a sufficient amount of skin disease. Drug-induced eruptions, I won't have a lot of time to talk about that. I'm happy to chat with folks offline about that or come back next year and chat about this. It's its own topic, and it's really fascinating to think about anti-TNF-induced psoriasis and other eruptions we're now seeing with some of our agents, IL-17-induced or exacerbated atopic and eczematous dermatitis and other things that are really interesting. Appreciation of burden of disease, again, that skin matters. And then thinking about examining our patients with these other at-risk skin phenotypes, namely inverse intertriginous disease, nail disease, and other things. I'll show you those in a moment. So this is just a representative sampling of one of the things that I see, depending on whether I'm sitting in the dermatology office or in the rheumatology office, I get a little bit of a different flavor here of what's coming across. And I will often have colleagues say to me, boy, I have this patient with psoriatic arthritis. I've started them on an anti-TNF. I'm waiting for it to kick in. And boy, their psoriasis just isn't clearing. And, and unfortunately, these are examples of nummular dermatitis, of eczematous dermatitis, contact dermatitis, and this is where some of the educational gaps in the co-management collaboration come in, because it's not psoriasis, right? And sometimes it can be a little bit tricky. It's not always clear cut. And so I think, getting more comfortable with this ourselves in terms of, just education and awareness, and otherwise just having a partner in this is another point we'll talk about. And I really like this. We've done some work on this over the years, and we had a publication a couple of years ago that showed that inverse psoriasis was common, in fact, and upwards of 20–25% of patients had some element of inverse or intertriginous psoriasis in body folds. What's interesting about this is what I found is we have a good number of patients who present with sort of a seronegative inflammatory arthritis, and they don't get a specific label. And in fact, if you get them undressed, if you look at some of these areas, I think it really helps us get to a diagnosis of psoriatic arthritis, looking in the gluteal cleft, looking in body folds, axilla, and other areas. And so something to think about. And in fact, this phenotype is associated with increased risk of psoriatic arthritis. Treat to target can cover your ears. I just point this out for the rheumatologist for awareness. I think he and I are more aligned than not, that not everyone needs to be below 1% body surface area. I think it's a shared decision-making point. However, if you're seeing a patient where you are giving yourself a high five in the office because you have fixed their joints, but they still have substantial skin disease, I think it is our job to offer them either ourselves a therapeutic intervention for that, or to talk about referring appropriately, and we'll talk a little bit about those overlap care models in a moment. So this is a scenario that's come up a few times. So the patient with well-controlled PSA, say on the TNF, but they have active areas of skin disease. To me, this is not a minor piece of the rheumatology practice around psoriatic arthritis. So let's unpack a few of those gaps again. So okay, patient's not clear. Treat to target would suggest they should be less than 1% body surface area. At least we're going to have a discussion to say, well, how clear do you want to be? Perhaps that means some topicals. And for some of my colleagues, I repeatedly get, and from the same people, the same question, well, which topical should I use, right? We'll talk about that a little bit. And you heard about those limitations today. And one of the big limitations is area, right? Is it genital, inverse, face, scalp, et cetera, based on vehicle, based on potency, and that may become easier in a moment. Ken alluded to this a little while ago. Familiarity with relative efficacy data. You're all experts now after this morning's talk, so that's no longer an issue. Consider other combination therapy approaches, and then thinking about co-management. But often I hear, but there's a long wait time for the dermatologist, or it's challenging to connect with them. So we'll talk about that as well, where we can bridge some of those gaps. So what are the solutions for the rheumatologist? Pick a couple of topical steroids you feel comfortable with, and just keep using those, right? And understand that they're what the couple of differences are. You could probably get away with 2 or 3 and do a whole lot of good with that. However, there are new non-steroid topicals coming. Ken alluded to this, tapinarof or Flumelast, some topical JAKs and other things, that may be one size fits all. Of course, it's going to be price and access like everything else, but wouldn't that be nice if you could just say, well, you have a few stubborn spots, your joints are doing well, here's a prescription for X, and try that while they're either waiting to get into the dermatologist or maybe they don't even need the dermatologist at that point. That's fine. Combination therapy was already covered, and we'll talk about the co-management piece. I'm not going to cover derm gaps. I'll come back to this, but just to say each specialist in this, arena has their own gaps. For dermatologists, it's mostly around familiarity and comfort with the musculoskeletal history exam, screening around PSA and other things. I'll spare you all here. It is highlighted, though, by, and as a segue to our discussion about care models, the GRAPPA group, of which I am a huge fan and long-term member. I think, Philip, now 12 years or something like that, believe it or not. It feels like a family to me at this point. Did this work a few years back, and they actually had a group from KPMG, the auditing group and consultant group, who came in and took a look at where are the gaps in patient care around this. I'm going to highlight a few as it's relevant to this discussion about care models. But they said that we needed to develop referral pathways and/or informal networks in order to really optimize care, and we needed to promote collaborative care between specialties to establish multidisciplinary teams wherever possible. And when you pay that much to a consulting group, you have to listen to them, right? So I still don't know what consulting is, but anyway, that's fine. Let's just keep going. So combined clinics and facilitated collaborative care. So, look, here's a list of all the sort of comorbidities and the things that we're supposed to be doing to get our psoriatic patients sort of buffed and optimized, right? We should be measuring their BMI, talking about managing their modifiable risk factors, talking about alcohol and sleep, treatment satisfaction, PSA and skin, treat to target, lipids. Now, so here's the deal. We do have to do all of these things for the patient. Now, when you say this to a rheumatologist, I think they get it. And they also would say, it's a little bit like asking my kids to clean up their room, put stuff in the hamper, right? They can do it. It's gonna, right, all right, fine. You ask a dermatologist to do this, it's a little bit like asking a dog to write a haiku, right? It's not necessarily going to happen. So there are ways around this, right? And so I think at the bare minimum, it takes a team, right? And so I think it's very fair to say to the dermatologist, you own the psoriasis treatment, you have to screen for comorbidities, namely PSA, and then just help the patient build their team, right? We're going to talk about that a little bit more. Make sure they're plugged in with their PCP. Where we are, we have these preventative cardiology clinics now for rheumatology diseases. It's wonderful. I have a colleague who really wants these patients and is going to talk about modifiable risk factors, et cetera, right? So just getting them plugged in and making sure they're plugged in with the folks that are going to get all these things done, if not owning pieces of it ourselves, and we'll talk about that. True combined clinic. So this is great, right? And it's a little bit... it's a bit of an ivy tower construct in some respects. Where it can happen, I think it's wonderful, but there are other models as well. There is data that these truly combined clinics, where you have a derm and a rheum together in the same place at the same time, do improve outcomes. This is one publication that showed that combined clinic care in those combined settings, that 46% of cases had a revised diagnosis, and they were much more likely to be treated appropriately with systemic or biologic therapy than before. Maybe not surprisingly, but I think that that's interesting. This is a little snapshot of our own combined clinic at the Brigham, where we have a dermatologist, a rheumatologist, a derm-rheum person, myself, rheum fellows, derm residents. We have a derm-rheum fellowship for 1 year, where either a dermatologist or rheumatologist comes through and cross-trains for the year. So it's great. It's a great education model. The patients love it. One-stop shopping. They only pay for parking once, right? They're thrilled. If we run late, they get we validate their parking. They're even happier. So anyway, and then of course it's a very rich environment for research as well, which I'll cover in a moment, and I hope helps to move the field forward to some degree. So this is great and it's wonderful. It's not practical everywhere. I'm well aware of that. Okay, and so what do the different collaborative care models look like? So there's these formal combined ones, and throughout different places in the country, we are aware of multiple different models. If you have one, we'd love to hear about it. Some that are in person every week, like ours, some that are monthly, et cetera, et cetera. Some are in tandem, but they're not on the same day. Some now are actually virtual. They have sort of virtual grand rounds. A couple groups get together, they share their complicated cases, they talk about it. Great. But some of the more practical ones are just connecting with someone in your community who is let's say on the derm side, who is not a cosmetic dermatologist. We're not recording this, right? That's a joke, yeah. Not a cosmetic dermatologist, someone who writes systemic agents for patients who need them, et cetera, and just finding that person and linking with them, right? Whether it's texting, phone a buddy. I will say if there's anything good that came out of COVID, facilitating these, discussions where HIPAA went out the window and we were texting each other for a little bit about patients and such. That was helpful. Communicate via electronic medical record. I'll come back to that. Sharing note templates is something, and I'll share it with you, a website where you can get some of those note templates with what the other party wants collected to understand why you're making the decisions that you're deciding on. And then really the key is just facilitated communication. And we have a few groups who have actually even agreed to hold a few templated slots for referrals that revert maybe a week or two before. They have one slot in their week for psoriatic arthritis referral or psoriasis referral, and they just keep it open so that you can get people in a relatively quick time frame. And all of these things can be helpful, and I'll share with you some resources to look at this. So all that said, I want to show you a little bit about how sort of forward-looking stuff. How has co-management and combined clinics in general helped to spur innovation? I'm going to talk a little bit about some work that's being done with GRAPPA, our Pac-Man group, and some others. And coming to Texas, I felt the need to show that picture. So I'm going to tell you a little bit about our Pac-Man group, which is the Psoriasis Psoriatic Arthritis Clinics Multi-Center Advancement Network Consortium. It's a mouthful, Pac-Man. Which really is focused mostly on these combined clinics, and I'll tell you a little bit about it. So it seeks to optimize the clinical care of patients with psoriatic disease through multidisciplinary collaboration, education, and innovative research. And really the focus is mostly on research, although we have educational and other goals around clinical support for these sort of combined clinics and supporting local regional collaborative partnerships. But really trying to harness the power of these unique combined clinic sites to try to move things forward. And these are a lot of the partners and partnerships that have happened over the years. I think really GRAPPA at the forefront of that. We've done things with National Psoriasis Foundation and others that I'll share with you. This is a nice review by Chris Richland that just talks about some of the strategies to improve outcomes in patients with psoriatic arthritis. You can see one of the highlighted items there is multidisciplinary care. And so what are some of the tools that have come out of this? So this is on the website. You're welcome to take a look. It's ppacman.org. And there's a toolkit for combined clinics and facilitated local regional partnerships there, so you can take a look. And I think it's very honest about challenges, financial and other, in terms of getting these centers put together. If you have a center and you're interested in joining the roster, please let us know by all means. The other thing is this. So we had this idea that, almost all of us are on some form of an EMR. For those of us, lucky enough to be at an academic institution and be on Epic, they've been formatted for Epic. But please, by no means did I mean that. Honestly, that was very much tongue-in-cheek. I'm tortured on a daily basis by this horror, right? But the point of these, they can be adopted for your needs as well. But what they include essentially is they're note templates. You can edit the way you like, but they have elements in there to remind you of what the other party needs. For example, for the dermatologist, it'll include elements on how to, what to use in setting up a patient for a biologic, vaccine requirements, recommendations. It has pieces for, the rheumatologist to remind them about what some of the skin treated targets are, what are we measuring, collective body surface area, it's one palm's worth of, et cetera. So you get the point. So there's content in there that you can use for your own purposes to collect what the other party wants to get where they need to be. I'll just jump to this to say that, the point of these combined clinics from a research standpoint is that they really bring a lot of value. You have a dermatologist there who's got the skin phenotyping and psoriasis expertise and seeing that at-risk phenotype for developing PSA. You have the rheumatologist who's doing the rheum assessments and has imaging expertise, which is increasingly important to, I think, the next level of what we're trying to do in psoriatic arthritis. This is a big push, for example, with the GRAPPA group, looking at imaging, ultrasound in particular, earlier in disease. Clinical phenotype and biospecimens can be collected in that context because we have clinical and basic scientists in the same place. We have the patient research partners there. And because of that, we've been able to get a lot of work done that I will breeze through over the next few slides. And I'll try to leave a few minutes here for Q&A, which is the request of our hosts. So very quickly, I'll show you where this is headed. So some of the hot topics have been, can we prevent psoriatic arthritis? In fact, if we better get a handle around who are the at-risk patients for developing psoriatic arthritis and think about treating them early. And so that's been a question. In order to get there, we've needed to do some steps along the way, including consensus terminology for what these preclinical phases of disease look like. This was an exercise that was done with the Pac-Man group and others and published not long ago. There's actually an ongoing prevention of PSA study that has finally started enrolling folks among a number of academic centers throughout North America. So this is something sort of exciting and really seeing things move forward. There are projects looking at combination therapy approaches, revisiting this after the RA experience with some of the combination therapies. We know now that combination therapy has hit IBD, and I think, it may be time to revisit what combination therapy looks like for moving the goalpost in psoriatic arthritis. I love this. I remember this is a number of years ago. I was with my kids in the New York City subway, and I saw this picture. I think this is even, sort of the pre-COVID era of people trying to get digital health, virtual health stuff kicked off. So anyways, I'll tell you a little bit about a digital health initiative that we have embarked upon. I don't know what he's showing his doctor there, but whatever it is, it can't be good. So Sage, Pac-Man, Sorcast. So this is just a really interesting forward-looking thing, and then I'll wrap up. So this is a digital health app that we co-developed with Sage BioNetworks. It's a group in Seattle, in Phillips' neck of the woods, where they've developed successfully apps around Parkinson's and others, where they could tell, for example, that having the phone in your pocket and just walking around, they were able to detect changes in your gait that suggested Parkinson's onset, Parkinson's flares, et cetera. And so harnessing some of those digital biomarkers, we've been looking at whether you can detect the onset of psoriatic arthritis through a variety of biometric features, both passive and active. There's also the ability to measure skin psoriasis activity, nail disease activity, dactylitis, and a variety of other things, all using this app, which has now actually been launched and is available at the Apple App Store. So you can play around with it, ask your patients to download it. Might be something interesting, and still ongoing validation to that end. I'm going to skip this for now, and just say that again, these combined clinics like ours have really helped to support, and around the country this is true, a variety of registries collecting really important data and biospecimens. There's groups like IPART. This is our local registry, Copper. There's several others around the country that have helped really, I hope, to innovate the disease area on behalf of our patients. So we talked about gaps. We talked about bridging those gaps a little bit around co-management and collaborative care models, and how those models are helping to move the field forward. A couple of resources for you. There's the GRAPPA Network URL there if you're interested in certainly joining us for any meetings, but also taking a look at some of the good work that's going on, and the Pac-Man website listed there as well with some of those resources I mentioned. Thanks to the organizers for the invitation.